Welcome to our weekly series of Healthcare Seeing Google Plus Hangouts, where we sit down with the top leaders in healthcare IT. Before we begin, I want to remind those watching live, you can tweet any questions you have to the account @TechGuy, or there's also a new interface for Q&A on Google Plus Hangouts, so if you can find that, we'll watch for questions there as well. But today we're excited to have the CMIO of Kareo with us, Dr. Tom Giannulli. Before Kareo, Dr. Tom worked at Hippocrates, where he drove the development of the Hippocrates EHR, which was recently acquired by Kareo and is now offered as a free EHR. Together with Kareo, Dr. Tom Giannulli is working to help small physician practices survive. I'm pleased to have him here with me today.
Thanks for letting me join in today, John. I appreciate it. Sounds like a lot of fun and look forward to it.
Great. Well, let's just dive in, and I think to start off, we should really hear a little bit about how you started developing an EHR at Hippocrates, and kind of what was your approach in developing the EHR?
Well, as you know, Hippocrates is really well known for its user interface and usability on its mobile product. So when we decided to take on EHR, we decided to take it on from the perspective that we want to build kind of a best-of-breed product from usability, make it very simple and intuitive. At the same time, build it for mobile from day one, so make sure that everything we do will translate to mobile well, and eventually build the native apps that we did build for iPhone and iPad. We also added some of the Hippocrates clinical guidance. So we have obviously a staff of editors that build our clinical content for the clinical data at that time. We use that same staff to build the clinical knowledge base that drove documentation and care plans within the app. So really the focus was usability, mobility, and then clinical knowledge built into the product.
Yeah, I remember when I first saw the Hippocrates EHR 2 or 3 years ago at HIMSS that it really was mobile focused, but I forgot about the whole clinical intelligence piece. Is that going to be transferred over to Kareo, or is there a relationship there to update it, or what's the approach there?
Yeah, part of the transition, we acquired the product itself, including the clinical knowledge base that drives documentation, and then we licensed a different database for the medication decision support. So you will see, say, LexiComp as our medication reference, but all the clinical knowledge related to documentation was built by Hippocrates.
Okay. All right. So what does the Kareo acquisition, really mean for the Hippocrates EHR for those that are interested in using it?
Well, I think Kareo represents an ideal home for the product. Kareo is one of the top vendors in PM and RCM services for small practice, and we were just rated #1 in that area by Black Book. So we have a good reputation there and a good set of technologies and products and services that really complement the EHR. And so together we have what's called the triple play, EHR, PM, RCM. And the reason that's important is that recent studies showed that about 90% of physicians and practices that are buying technology want kind of one vendor to solve all those problems for them. So we really now have a product line that matches what the market's looking for. And Kareo, as a technology company, is very mature, and we have a very stable platform that we've integrated the EHR into to kind of make it a tightly integrated product offering. And then as time goes on, we're making that more of a seamless offering by integrating and converging all the technology.
So, Kareo now is, made big waves when they announced this free EHR and the acquisition of this EHR product. And so now, Kareo's kind of put their bag in the free EHR model. Is that right for small physician practices? And I mean, in some ways, some say, well, aren't they basically paying for the EHR when they pay for the Kareo PM? Or, what's your view on the free EHR model?
That's a good question. We're really a freemium model that, true to its form, there's no strings attached for the free product. So the benefit is the doc can come on board, play with the product, actually use it in his practice with actually no requirement to upgrade to a paid product. So that's free support, free technology, fully loaded, nothing's held back. And then once they want to really go to an integrated solution, then we would offer you our paid products at a reasonable rate, of course. And as I mentioned earlier, since about 90% of the docs want a single point solution, single vendor solution, if we get you excited about our EHR, there's a very good chance you'll move towards our paid products when you solve that entire practice problem. So we feel pretty confident the model is a good idea. It actually is working in our case, and so we're confident that we're going to continue with that model.
Yeah, I think it's an interesting approach. I know I have a regular reader who often comments on my blog and says, all of these EHR benefits that you say, financial EHR benefits, are really PM benefits, not EHR benefits. So in some ways, I guess it almost makes sense that you pay for the PM because you got the financial connection to it, whereas the EHR has a little more challenging financial connection.
Yeah, I think the ROI in an EHR is softer than that of a PM. Obviously, PM is a requirement for doing business or using an RCM service provider, or else you're not going to get collections managed. So, but I do believe our EHR do have a good ROI once they're well integrated into a practice.
True. I think soft costs or soft benefits is true. Things like legibility and other things that can be argued. So, let's dive in more on kind of the title of this, which is really, does the small physician practice have a future in healthcare?
That's a really good question, and obviously our company is focused on the small practice, so we think that we have a really good answer to that question. I think as the healthcare organizational changes evolve, today we have organized medicine in the form of ACOs and others. You're going to find that the small practice has some unique differentiators that can't be replicated by those larger organizations. And they really center around engagement with the consumer, intimate knowledge of their continued medical history, continuity of care, kind of bringing to the fore, the private practice brand of medicine, which is really not profit-driven. It's not a corporate initiatives that drive that. It's really about the individual practitioner and their need to do well by the patient and be the best doctor that he can be. So the motives are a little bit different. I think that the attention to detail and the personal relationships are different. And I do believe that if you were to survey people and ask them, would you prefer, a well-run private practice where you get kind of high engagement with your doctor, all the technology applied, versus going to kind of a corporate medical institution and going through that process, you'll find that people would prefer the smaller practice model. Now, the challenge is, how do we get that small doctor to act, more organized like a big practice? And really that comes to the technology and the services that they need to integrate, and also the will to kind of change the way they do business today. And we think we can support that using our products and services, but it also takes a conscious effort by the doc to really decide, look, I'm really organize my practice to be competitive and also be designed to engage the patient in ways that I haven't maybe done before.
Yeah, I mean, I think your point's interesting when it comes to primary care, because primary care is where they should be getting a lot of their care, although that's really changing with this, at least it's kind of changed already in the healthcare system in the US, where you're going to specialists so much. And so then you have all these independent specialists, or they're going to have to refer to the big organization anyways because they're the only ones with the specialty. So is that going to be a challenge because of the specialized care that that we often have to get?
No, I think that clearly the gatekeeper model, which is kind of an HMO model, may or may not be the pervasive model. But at any rate, there is a manager of your overall health care, which is generally your primary care provider. And so even the specialists have to kind of communicate back and forth so they can understand what's going on with you and track in between specialists. So I think there's a drive towards that model. And again, I believe that the best way to represent that type of care is through a small practice, though I'm not saying the larger practices are not effective or efficient. I just think that the unique differentiators in the small practice make that a little bit more engaging and probably a higher customer satisfaction overall if that small practice is run well. So I don't think the small practice is going anywhere if indeed they can automate and use the technology appropriately. And the other point that you talked about is how do they play into the larger organized medicine? And I think there's a lot of data exchange that's in play today through HIEs that really allow the large enterprise to talk to and integrate care with the small practice without sacrificing a lot of their IT investment and efficient practice model or best practices. So again, if the small practice decides they want to integrate using technology, they can really fit into that infrastructure, and the large practices don't feel like they're giving something up in terms of efficiency by dealing with the independent small practices. If they don't, I think there will be some conflicts, and there will be some more further isolation. So I really believe that the small practice can survive and actually thrive for the reasons we talked about, but they really need to automate and integrate as effectively as possible.
Yeah, I've often said that I wish the stimulus money was focused on integration and exchange of information, because you can't do that without an EHR, right? Like, I mean, no other organization wants to integrate with you if you're on paper. I mean, the only way you can send it is a fax or a scan, and that's not high quality.
That's true. There's also studies that show about 50% of patients, when they're surveyed, prefer to see a physician that's automated than one that isn't, because they can do things online, they can get results, they can interact, and it's a lot easier for them to conduct their business and to integrate their healthcare without having to go through extra maneuvers that you would go through with someone who's paper-based. So I think the patient-centric movement towards healthcare is driving that. The patients are going to make those decisions because now they have more buying power with the high deductible plans that are out there and the savings accounts, healthcare savings accounts. The individual has much more say in who they can go see and what they're paying for, and the physicians in small practice can respond to that in a very positive way and garnish more favoritism that way as well. So I think that it's all driving towards patient-centric medicine, and small practices, I think, have an advantage when it comes to patient-centric medicine. So that's kind of the logic behind the argument.
Interesting. I think the idea of high deductible plans being an amazing opportunity for small physician practices is quite interesting. But the question is, can they really differentiate themselves in service levels and other things that say we're better than the large organization?
I think the opportunity is there, and I think there's some proof points on the table. Are you familiar with One Medical?
I think I've heard the name.
One Medical is a kind of a startup, if you will. They're in several cities now, major cities, and they really offer a very unique brand of healthcare where it's very consumer-centric, highly technology-based, very easy membership rates, and you get preferred engagement with your doc, and the continuity of care is excellent. So what you're seeing is that's going very well. They're growing. They were just raised a large round of funding, and the demand for that service is pretty high. So I think that there's some examples of how being creative and being well integrated really does help, the healthcare space as well as the consumer.
Sure. No, we have something going downtown Las Vegas that basically I've considered, because I'm on a high deductible plan. It's like, should I pay extra for that personalized care so I avoid, all of the regular high deductible expenses? So we'll see how that evolves. So, how about, what are some of the other pressures that are really facing small physician practices today?
Well, I think it all, there's so many of them, but a lot of them are related to government regulation. Obviously, there's the meaningful use criteria and requirements. There's HIPAA omnibus that just became final. There is ICD-10 changes that are coming down the pipe next year. And then that's all surrounded by a massive organizational and reimbursement model change that Medicare is going through in the next 5 to 10 years. But that's a lot of uncertainty out there. But I think the one constant is that patients will be making more of the healthcare decisions on their own, and quality of care and engagement with the patient is only going to help you become more competitive, regardless of which model you operate under. And if you want to stay small and independent, you just need to move towards that direction. I think you'll be fine. I think there's a lot of changes that may come out and be temporary. I think ACOs as a model are thriving, but at the same time, 9 of the 32 pioneer ACOs decided to call it quits, so to speak. So they're no longer engaged in that model. So it's hard to say whether that's really gaining momentum or losing momentum, but I do believe there'll be some changes. And again, maintaining that customer, patient / consumer focus is really, I think, that the main point that the small practice needs to focus on. And that'll make them better suited for any change that comes down the road.
Huh. So it's interesting. You're almost arguing that the way to deal with the ACO model or the ACO pressures, the changing reimbursement from fee-for-service to value-based healthcare, is that they should provide value-based healthcare, like that they should provide a higher level of customer service and a better service that's focused on the patient as opposed to just funneling through as many as they can.
Exactly. I think that's going to be the winning combination, and I think that in any other business model where the consumer decides how to spend their money, they generally lean towards value and convenience, and that's really where healthcare needs to go.
It's interesting though, because what you just described there is that the physician practices should focus on how to make healthcare convenient for the patients, but it turns out that's great for value-based healthcare as well, because if it's convenient, they'll get the care that they need, which isn't happening today, right?
Yeah, I think there's definitely some challenges, and I think that technology is one of the key elements that the small practice has been kind of slow to adopt, where large organized medicine is like the first thing they do is integrate and get technology infrastructure up and running. And I think that's the playbook the small practice really has to change their way of thinking and really adopt. And that's where they can leverage that opportunity to differentiate themselves on a patient-centric basis. So I think they have more of an advantage once they automate. But again, if they don't automate, they will not be considered, I think, as changes occur.
So I mean, I guess you can speak from the Kareo perspective, but it almost seems like EHR vendors are too busy focusing on all the government regulations, meaningful use, 5010, ICD-10, et cetera, and they're not focusing on enabling the physician practices to offer these types of services. So how do you balance that, the regulation requirements that, of course, every doctor says you need to have, and then in some cases you have to, ICD-10 in a year, but, between that and creating a system that really provides that new type of patient care?
I think it's a real challenge for IT vendors such as ourselves to really balance that, but we do, I think, a pretty good job, and we obviously have a lot of overhead that goes into building those meaningful use requirements into the technology, and that takes time and cycles. And while we're building that into the product, because that's definitely a direction we're going, we have a lot of designs and plans towards making the product consumer-centric and consumer-friendly and automating some of those tasks we talked about. While we're doing that, we also have a business that's a service business that you can subscribe to that allows this service to actually answer the phones for you. So you redirect your phones, they answer the phones, they take some of that burden off you, they offer some value-added services like refills and other things to make it more consumer-centric, can communicate results from the system that's in the EHR essentially to the patients for a practice, and using kind of a manual bridge, if you will, until we develop all that technology out to make it fully automated. So we definitely want to solve those problems, and we can do that a couple different ways, but adding the human element and kind of a human service model before we get to the fully automated model is definitely part of our structure today.
Mm-hmm. So let's talk a little more about meaningful use. Like, is meaningful use reasonable for small practices?
My personal opinion is it's a little overreaching with respect to the requirements, the depth of requirements. They've kind of missed the mark. I think what you said earlier is very true, that I believe that their job at meaningful use was to really create a situation where data exchange was unfettered, and that you could, as a small practitioner or a large organized medical entity, exchange information freely in a standardized format, and that was a mandate, that you needed to do that. And that's part of what Meaningful Use did, though it kind of falls short of actually making it happen. Well, as Meaningful Use 2, they're trying to promote that, but at the same time, I still think there's opportunities for organized medicine to kind of wall off that data to a certain degree and not really let the smaller practices exchange. So I really want to see that open up. I'd love if Meaningful Use redirected itself and just focused on data exchange and openness of information and really mandated that to occur, and also made it very transparent to the consumer market who is playing and who isn't. So if there was a grading system that was published that said, look, this organized healthcare system gets an A+ for exchanging information across the board and making data very transparent, that's where I think the Meaningful Use standards should really focus. Not so much on technology, not so much on usability and small, intricate, technology-based solutions and how those are built or what the feature list is, but more in big block conceptual things that really relate to data transportation and data transparency.
So if these large healthcare organizations, which every community has, every metropolitan community has at least, if they decide to create these walled gardens, which they still can, the regulations don't require it quite yet. If they do, does that crowd out the small practices and kind of give the larger organizations an advantage over them?
I believe it does. I believe it's a challenge that we really need to meet for the benefit of the healthcare system in general and patients. So I do believe that the government is, in the ONC, will move in that direction. I think it'll eventually get to the point where it becomes mandated that data does get exchanged. But like you said, it's not something that's necessarily on the table today in concrete form. So I do think it'll get there. I'd love to see it happen faster than it's happening today. But you're right, it does pose a threat to a certain degree to the small practice and integrating into the system at large.
And I'd love your you suggested tangentially that maybe we should expose the hospitals that aren't, that are doing an aid grade of integration versus those that aren't. But as a blogger, I think the challenge is, I think most physician practices have a relationship with that hospital, so they don't necessarily want to be a whistleblower that organization is bad at integrating. So I'm not sure how you bring that to the forefront other than maybe legislation.
Yeah, no, I think there could be an organization that is kind of independent that looks at these things and makes them public. I think that would be a service the government could take on. As part of their ONC responsibilities to create a grade sheet or a transparent grading system for hospitals and data exchange. I think that would be reasonable.
Yeah, we know how good government is at transparency. So do you think that the EHR incentive money and really even maybe more so the future penalties are having a big impact on the small practices?
I think initially they had a huge impact. I think the data supports the fact that EHR adoption, e-prescribing adoption went from 20 to 30 to something like 80 or 60, 70%, depending on what studies you look at. Either way you slice it, there's been a big shift towards automation, which is great in itself. I think data exchange is just the next step within that movement. And so meaningful use, I think, is powerful and useful. The incentives are becoming a little bit diluted because the requirements are becoming a little more arduous. So you have to have a full year of reporting versus 3 months. The cost of managing the systems may go up in that full year. The ability to migrate your technology in some cases may be difficult, and that's going to make you decide, oh, I'm not going to continue with meaningful use because the technology upgrades for my client server EMR is so manual and so costly. So there are some things that tend to push you away as meaningful use evolves. So that's another reason why I'd like to see meaningful use become more of a larger conceptual model that has little to do with the actual technology or software you're using, but more how it's used. That would decrease some of those barriers that they're putting up right now.
Yeah, I guess Mandy wrote a post on EMR and HIPAA.com that was just posted this week that actually looks at an IDN that has multiple EHRs under the same roof, and they actually maybe are a couple upgrades behind, and you have to do each one individually. And there were other pressures to about when you could upgrade, and so you look at that. So I guess in many ways maybe meaningful use is easier for a small physician practice that only has 1 or 2 docs, or a small group that and is on one EHR with 1 PM. Maybe I guess it's easier for them in some ways.
Right. Yeah, I would agree with that.
So how about ICD-10? Are physician practices ready for it, or have they? I mean, I think most hospitals have some sort of ICD-10 project, but is the same happening for small physician practices, or are they just kind of saying, "Oh, I'm sure we'll be fine"?
ICD-10 for kind of a modern technology platform product like Kareo is pretty simple to manage. It's not a big deal. It's something we can manage very easily and won't disturb the practice much at all. For other older systems, client-server legacy systems that have kind of data schemas that don't support that data set, and were designed in from day one, it's going to be much more of a challenge. So you're going to see some disruption. You'll see a lot of migration, to be truthful, from those older systems to the more modern SaaS-based systems, just because migration is so much easier. And then further migrations or changes within the code base are going to be much easier to manage. And I think people are just realizing that, you need to upgrade to more of a SaaS model just for these reasons plus some others.
That's interesting. So ICD-10 could drive EMR switching. That's interesting. We'll see.
So if you think you're going to switch your PM and then you have 90% of people wanting a single vendor solution, then necessarily they'll probably change their EHR. So you'll see a lot of transition. And the data supports the churn now is around 50% from one EHR to the next. So I think some of that plays into how the billing system has been upgraded or managed.
And we just had the HIPAA omnibus rule go into effect. Have you seen a flock of users coming to Kareo saying we need new business associate agreements, or can you help us with compliance, or is it basically deaf ears and they're waiting for as one doctor one time told me, he said they're not going to throw us all in jail.
Right. Yeah, I believe that there's some movement there. We actually took care of that early in the year, so we've already completed all those transitions from Agreement A to Agreement B, and it's pretty transparent. Most people didn't even really realize what was happening. So I don't think that's really going to be an issue for our company and our customers, maybe more so for larger organizations that have lots of partners that have to be compliant.
Interesting. Well, I thank you for your time here. Any last thoughts on the plight of the small physician practice? Is there hope, and what do they need to do to be viable in the future?
Well, obviously we're focused on that. So every day we kind of live and breathe those issues and those concerns. And I think we offer solutions for those problems. So as a small practice, I would encourage you to come look at our Kareo website, understand what we do and how we can help. And again, our value proposition is to promote your business and to make you successful. So we're all on the same side, and hopefully that will work out for everybody.
So if the small physician practice fails, Kareo fails. Is that safe to say?
I don't think I'd go to that point, but let's just say that we're definitely in the same boat, and we're gonna oar the boat and make everyone successful at the same time.
Excellent. Thanks so much for your time. So glad.
Thanks again. Take care.